Good afternoon, everyone. My name is Vishal Gupta. I'm one of the ICU specialists here. So welcome to the weekly echo teaching. So today we will be talking about mitral valve prolapse. It's a very tricky topic, and it takes some time to get around the things. So just give me a sec to move this. So the most important thing about mitral valve prolapse is it's very, very important to understand the anatomy of the mitral valve. If you have good understanding of anatomy of mitral valve, then I think it's not a very difficult topic. So I'll spend a little bit of time on discussing about the mitral valve anatomy, then we'll discuss about the mitral valve prolapse. So main things we'll be talking about the mitral valve anatomy, then talking about the sonographic anatomy, then talk about the prolapse, and then we'll discuss some cases. So as we know, so mitral valve has 5 parts. So mitral annulus, anterior and posterior mitral valve leaflets, commissures, and chordae tendineae, and papillary muscles. So these are the 5 important structures of the mitral valve. We'll talk about one by one each structure. So mitral annulus, which is a saddle-shaped structure, and it encircles the valve orifice. It's a fibroelastic ring, and it is elliptical in systole, and it's circular in diastole. You can see anteriorly there's an aortic valve, and laterally there's a left atrial appendage. And in terms of leaflets, so 2 leaflets, so big anterior and small posterior. So the anterior leaflets, you can say it's a large and it's a thick leaflet, and it covers a 1/3 of the ring. It has better and strong anatomical support, and 3 scallops, A1, A2, A3. Whereas posterior, it's a thinner, smaller, and more flexible, but it covers a 2/3 of the ring. Its anatomical support is not that great, and that's why posterior leaflet prolapse is more common, especially P2, and scallops P1, P2, and P3. And in terms of commissures, so 2 commissures, anterior posterior and posterior medial. These are the specific sites where leaflet inserts on the mitral annulus. There's a chordae tendineae, so these are the fibrous strings that attach to a specific portion of the mitral leaflets. Around it is length 20 millimeter and thickness around 1 to 2 millimeter. And there are 3 types. So the first is primary. So it attaches at the leaflet tips, and it's very important to make the coaptation line. And if there's a failure of primary chordae tendineae, then it can lead to rupture or elongated chordae. So it's very, very important structure. Whereas secondary, it attaches the mid body of the leaflet. Even if there's a rupture, it's not necessary that it will affect the coaptation line or there would be any horrendous regurg. It's not necessary. Whereas the tertiary, it attaches the base of the leaflet. It's merely it's helping the structural support. So the primary chordae tendineae is the most important structure, you can say. There's the papillary muscles, so 2 papillary muscles, anterior lateral and posterior medial, and normally it's located at the junction of lower or apical third or middle third of the left ventricle. So now let's talk about the sonographic mitral valve anatomy, which is very interesting. So you can see the top one is in surgeon's view. When during intra, that's what they see, and when we do the echo, so that's the view we see. So we'll talk about bit by bit. So this is a sonographic view. So anterior mitral valve leaflet, posterior. So the main the important bit is that how to differentiate whether it's anterior structure or it's anterior leaflet or the posterior leaflet. So what normally I do is I always look for where aorta is. or where the right ventricle is, because right ventricle is anterior structure. So whichever side is the right ventricle or aorta is, that is the anterior leaflet, and the other is the posterior leaflet. And to check which is P1 or P3, so P1 and A1 is always is a lateral structure. And in that case, I look for where the left atrial appendage is. So wherever the left atrial appendage is, that would be either A1 or P1, and the opposite side would be A3, P3. So always look for either aorta or right ventricle or left atrial appendage to decide which scallop you're talking about. So to start with parasternal short axis. So standard view is the same as sonographic view, which we just were talking. So anterior posterior, and down there you can see this anterior posterior. So look for the aortic valve or the right ventricle. So that's why this is anterior, this is posterior. And this side is lateral medial, so A1, A2, A3, and the P1, P2, P3. This is lateral, this is medial. And parasternal long axis. So if you just transect at 90 degree, so you will be transecting through the aorta in the middle of A2 and P2. So parasternal long axis. So this is the right ventricle, this is the aorta. So this has to be anterior, and then it's posterior, and it's transecting in the middle. So that's why this is A2 and this is P2. It's the apical four chamber. So in posterior is transecting the P1, whereas in the anterior is transecting the A2 and A3. So over here, so this is apical four chamber. Normally, if we open it a little bit anteriorly, there would be aorta coming down here, and this is the right ventricle. So that's why this has to be anterior, and this is posterior. And now we just saw that the posterior part is the P1, and the anterior part is A2, A3. So apical four chamber, P1, A2, A3. With apical two chamber, so I've highlighted this, EN2. So I'll tell you why. So it is transecting posterior, then A2, then the posterior P3. So it's the P1, A2, A3. So in apical two chamber, A2 is in the center. That's how try to remember. So A2, it means A2 comes in the middle. So P1, A2, A3. Oh, sorry, P1, A2, P3. That's how I try to remember. So A2 in apical two chamber in the middle, and other is P1, P3. So this is a summary of transthoracic echo. So this is the short axis and parasternal long axis A2, P2, four chamber P1, A2, A3, and apical two chamber A2 in the middle. So P1, A2, P3. And so let's talk about the transesophageal view. So this is in the summary of all the view, but we'll talk about one by one. So in the mid-esophageal four chamber, so this is at 0 degree. So it's going transecting the A2, P2 again. So again, so this is the right ventricle. So that's why this has to be anterior. Other side, posterior. Transecting in the middle. So that's why it's A2. This is P2. So just remember that mid-esophageal four chamber view is same as that of parasternal long axis. So A2, P2. And then mitral commissural view, and which is at 60 degree. So again, so mid-esophageal mitral commissural view is the same as that of transthoracic, two chamber view. A2 in the middle. So P1, A2, P3. So P1, A2, P3. So mitral commissural view is the same as that of transthoracic two chamber view, which is P1, A2, P3. And where's the two chamber view? So two chamber view, which is at 90 degree. So, I try to remember that mainly it's the anterior leaflet. So this is the only view where you can see all the three scallops of anterior leaflet. So you can see it's transecting the whole A1, A2, and 3. So anterior leaflet, there's all three, and A1, A2, A3. And where's the posterior, just a little bit of posterior, which is P3. So mid-esophageal two chamber view, you can see all the 3 scallops of anterior leaflet. And you can see there's a left atrial appendage, so that's why this is A1, this is A3. And long axis view, it's the same as that of metaesophageal 4-chamber view, but other way around. Now A2 has come to this side, P2 on this side, so A2, P2. But because aorta and right ventricle on this side, so that's why this is anterior, this is posterior, so A2 and P2. So I know it's difficult to remember all the scallops, but it's just that if you just orient yourself, then I think just need to do it again and again. Then I think it should not be that difficult to remember. And this is just the Sam's, famous hand, just showing that if you just look at like this is, this part bit of anterior, then posterior is making this your hand, posterior, and just different ways of remembering, the leaflets. Now, I've just put a few, video clips, so we'll try to guess the leaflets because Luis, it's only you, so you need to guess all the leaflets.
Okay, transesophageal, looks like mitral focus. So the leaflet, the anterior one is on the left.
So no, just guess, where the arrow is. What is that leaflet? That's it.
Oh, anterior.
And which scallop?
Either A2 or A3.
So A2, because metaphyseal 4-chamber transecting in the middle, so A2 and P2. Nice.
So which leaflet? It's going to be the posterior.
Yeah. Scallop.
Oh, eek. P1.
Very nice.
Oh, so this is the fantastic 2-chamber view with A1, A2, A3, and P3. So posterior.
So it's 60 degree.
Oh, look. So left atrial appendage is to the right of the screen.
Yeah.
Which means that's posterior.
Yeah.
Which means that P2, P1?
P1.
Had to be one of them.
P1.
So another commissural view. Posterior.
It's a 0 degree. But it's a transgastric.
Wouldn't it still be P2?
Yeah.
But it's P. I did guess P. I did guess P. Isn't that the same as the one you had before?
Yeah,
A2?
but arrows are different, yeah. So.
P2?
Yep. That's the last one.
Oh, A2.
So quick. Very nice. Thanks, Lois. So, mitral valve prolapse. Let's talk about that now. So this is your left atrium, left ventricle. So, mitral valve prolapse. So this is your mitral annulus line. So this is a posterior displacement. So your posterior displacement of mitral valve leaflet, at least 2 millimeter, and your tip of the leaflet should be pointing towards the apex. So 2 millimeter displacement, leaflet towards the apex, and there may be thickening of the leaflets. So that's your prolapse. And how to differentiate between flail and prolapse? So if your mitral leaflet tip, if it's pointing towards the left atrium, that's the flail segment. If it's pointing towards your apex, that's prolapse. So basically in flail leaflet, it's pointing away from the apex, which is toward the left atrium. And flail normally you see with the torn cordy or ruptured papillary muscles. And normally it's associated with acute and severe MR. And in terms of classification, so myxomatous, and that's a primary, and the secondary, which is mitral valve prolapse syndrome, and then the functional. So myxomatous mitral valve disease. So also referred as classic or primary mitral valve prolapse, and normally middle-aged males 40 to 70 years of age, and could be familiar, non-familiar. Normally, you know, there could be connective tissue disorder in the background. The main, you know, characteristic is there's an increased redundancy or thickening of various portion of the mitral valve leaflet. Whereas mitral valve prolapse syndrome, it's also known as non-classic mitral valve prolapse. So you can, you know, normally we see in young females between 20 to 50 years of age, and normally they present with some dyspnea and non-specific mid-systolic flick. And you would see in the echo there's a displacement of mitral leaflet, you know, more than 2 millimeter, and there could be no or very minimal mitral regurg. Whereas the secondary mitral valve prolapse, which is also known as functional or hemodynamic mitral valve prolapse, normally there's either reduction or alteration in the left ventricle cavity size or shape, and that can cause mitral valve leaflet to move past the mitral, you know, valve annulus during systole. And you know, disease like coronary artery disease, rheumatic heart disease, cardiomyopathy, hypovolemia can cause this functional mitral valve prolapse. Normally presentation. So first of all, it's the most common cause of isolated mitral regurg, and patient may be asymptomatic. You know, normally, you know, like in young female patients, mitral valve prolapse syndrome, or patient can present with fatigue, dyspnea, exercise limitation, all the features of mitral regurg basically. And the main echocardiogram features. So to start with M mode. So this is your diastole, this is your systole, and E wave, A wave. And so if you see it here, so there would be sagging of, you know, either anterior or posterior mitral valve leaflet. So you would see systole. So this is the systole. And so this is anterior leaflet, this is a posterior leaflet. So if there's a posterior valve prolapse, so there is sagging of only one component. If it's both, there would be sagging of both the components. It's not easy to pick up on the M mode, but you know, it's not uncommon to see on the M mode if you see it carefully. On the 2D mode, so first of all, you know, the displacement, you know, that 2 millimeter, normally we always measure in the parietal long axis. So that's the only view which is, you know, recommended and validated. You can use the apical four chamber, but then the 2 millimeter displacement is not adequate. That's in anterior mitral valve prolapse. If you're using the apical four chamber, then more than 1 centimeter displacement is recommended. So basically, you know, you shouldn't be using apical four chamber to diagnose it. Parietal long axis is the most commonly used view, and the same as that in posterior mitral valve leaflet prolapse as well. Other features, there could be thickening of the leaflet, some left atrial dilatation, volume overload pattern, and as I mentioned before, that P2 is the most common cordy rupture and the prolapse because weak anatomical support. And in terms of Doppler, you know, you may see the Doppler regurg, and the direction of the regurg may give you the clue that which leaflet is affected, and it's always opposite to the affected prolapse leaflet. So let's go through a few cases now. All the cases for you.
Thank you, Vishal. Sorry, how old was the male? He was 52.
52 and just when he onset AF.
Okay, so starting from the top, no significant pericardial effusion. The right ventricle looks comparatively normal size and is contracting okay. Aortic valve leaflets are thin and mobile. The mitral valve looks like there is significant movement of the anterior leaflet directed back into the atrium. The left atrium is probably enlarged. And then looking at the mild to moderate mitral regurgitation according to the colour, and which is not quite, is slightly oblique, that view, because we've lost the aortic valve, and it is directed, not sure which direction that's been directed.
Yeah, it's not exactly directed. It's a little bit in the center, to be honest. Let's see the other view.
Okay, so looking at the parasternal short axis view at the level of the commissures, you can see that the regurgitation is happening in the middle segment, but I cannot tell which is prolapsing.
Yeah.
So that looks like the posterior leaflet is the one that is prolapsing, because it looks like it's just, it's certainly more than 5 millimeters, can't tell exactly, and the jet is directed anteriorly.
Is it mild, moderate, or severe? You said it's directed posteriorly. What do you think about the severity of it? And what other views would you like for the, you don't mind just going back? Yeah, exactly.
For this one.
So the question is, how severe do you think the regurgitation is?
So it's
And
curving round and hitting the posterior wall. I would like to see the pulmonary venous systolic diastolic waveforms.
Looking for
diastolic reversal.
anything else to point to the severity on that? So you say hitting the back wall, you say is severe?
It is often severe. The eccentricity of the jet underestimates in terms of the volume of the colour.
Yeah, and what's the underestimated? What's the effect that makes it underestimated? What's that called?
Coanda.
Beautiful. And anything else on that that can maybe give you an indication of severity?
The fact that the left atrium is enlarged.
Okay.
You could look at you could calculate the volume of regurgitation and the effective orifice of regurgitation, or the pressure half time. No, not that one, not the pressure half time.
So let's work through all the modalities. I've always got a few of them. So we've got the 2D features. So what are the 2D features might suggest it's severe?
We're talking with or without colour Doppler?
Without colour Doppler. So the way I always think about it is
the degree of prolapse.
Yeah, because there's a
Yeah.
bloody great hole there that we can see straight away. So straight away we're going to say that 2D features suggest it's significant. Then the colour, you've told us that you can't trust the area because of the Coanda effect. That's absolutely right, but it hits the back wall, suggesting it might be severe, as you said. One other thing on colour. There are two other things on colour that can give us severity. Work your way up. So first of all, it's the Pisa effect. There's a massive Pisa. You
so
see.
the vena contractor and
So there's this.
The Pisa effect.
There's this huge Pisa effect here, and even if we don't have to measure it to give us the orifice area, we can still see this huge sort of ball that's sitting there each time systole happens, which suggests it is severe. And the next thing is this massive vena contractor. Again, it's got its limitations because of in a prolapse, absolutely, but worth mentioning. So that was 2D in colour. The next one would be continuous wave Doppler. it's going to be a bit rubbish, isn't it, when we put it through here, because you can't get the angle, but we should say that. Then the last thing would be pulsed wave Doppler. So pulsed wave Doppler in two spots. First of all, you mentioned it in the pulmonary vein that comes in, looking for the
Except that
systolic flow.
you would want to find it in a pulmonary vein that wasn't
Nice.
directly in line of the jet.
Fantastic. And then the last bit would be pulmonary, the last thing would be the pulse wave at the leaflet tips up in there. And what are we looking for there?
Inflow velocities.
E-wave greater than 1.2, which is associated with severe. Really good. So again, just in the exam, they'll totally would give you that picture and then ask for rapid fire, and just, as I say, to make it easy, I split it up into the different modalities and just have that on the tip of your tongue for the exam. Cool.
Thanks, Sam. And there's one more window. I think that's just the zoomed view on the same parasternal axis.
Yeah, so it's definitely more than, hang on, 8, 10. It's more than a couple of millimeters.
Can give you a measurement.
No, you can't. You need to
So which scallop you're talking about?
So this is the posterior.
Which scallop?
Which scallop? P2.
Thank you. Okay, let's do case 2. Sorry, Lois, it's just.
I'm missing a great tool.
Yes. Yep. So this is a 4-chamber mid-esophageal view. We're showing us the most obvious abnormality is the mitral valve. There's a lesion attached to the posterior leaflet, which is flicking in and out.
Which scallop?
Oh. P2.
Yeah, thank you.
But you're not actually showing this. You're not actually showing the Doppler across the mitral valve.
Yeah, it's, the window, it's not perfect. My bad.
So what do you, there's the
Just-
interatrial septum.
It's just the, direction of your vital regurg.
Oh, okay.
Just anteriorly directed, It's not ideal, but still you can see it.
With the eye of faith.
We'll
Not
give you
with
better
my
one.
glasses.
We'll give you
Not with
better
my
one.
glasses.
We'll give you better one.
So is this the same? This is the same patient.
Yeah.
Okay, so yeah, then I can see that the jet is anteriorly projected, which suggests that the problem lies in the posterior leaflet predominantly. So whether or not there is a hole in the leaflet would be hard to tell on that. Can you put on tissue priority?
I can give the different view. That's all.
So the lesion is approximately, I don't know, 5 by 4 millimeters, flicks in and out, appears to have a stalk.
Louis, can you remind me all the scallops in this view, please?
Oh, you rat bag. So this is the 2-chamber view,
Yeah.
and I've completely forgotten.
It's mainly this is the only view where you see
Okay,
all the
A1,
scallops.
A2, A3,
Yeah.
and then P3.
Yeah, very good.
So it's actually, well, it doesn't really tell you which bit it's attached to because it's got independent motion.
But in this beautiful, you can see this is
This
A1, A2, A3,
A3.
and that's P3. Very nice. And the last one.
So we still see the same lesion attached to the posterior leaflet. Oh, okay. It looks like we can see some prolapse
Yeah.
of the anterior leaflet. Because if that, I'd have to slow it down and look at it. I
It's
can't-
mainly it's the posterior.
Yeah.
So, and what are these scallops? the long axis here.
So this is equivalent to the parasternal long, which means that it has A2P2.
Okay. To summarize, this case, what's going on?
So it is, so there is a mobile mass attached to the posterior leaflet of the mitral valve, which is consistent with endocarditis.
And
And
prolapse.
it is associated with mitral regurgitation, but you haven't shown me enough views to determine the severity.
But the prolapse.
The prolapse. Does that really count if it's infected?
I think there are two things going on. One is there's a vegetation, and also there's a prolapse of P2 segment.
But we wouldn't report that as actual prolapse, would we? If there's infection involved, wouldn't we just say?
Yeah, I think so.
Yeah.
But keep going, I think, with it. So what we don't know is if it's, I guess, if it's new or old. But either way around, it was an MSSA bacteremia, wasn't it?
Yeah.
So MSSA,
Strep
we know,
Miller, wasn't it?
Strep Miller.
Oh, Strep Miller.
Yeah.
but again, it's a aggressive bug that can eat away at valve leaflets. Do you think, from what you've seen, would you suggest that's mild, moderate, severe regurg?
At least moderate.
At least one, I think it's looking severe.
Yeah, severe.
You know, because it's got that horrible kind of effect and all that coloured up, even though the scale is a bit off, of course.
But how do you tell that in a
Because look at
transesophageal echo?
the hole that we've got
Coarctation.
stuck in there. And then the classic thing would be saying, what other views do you want? I'm sure Vishal would want to show if we've got pulmonary veins.
Sorry, I don't have. But it's mainly concentrating on mitral prolapse.
But the bloody great hole that's sitting in there and that thing that's flicking around makes you think that we've got.
Well, hole implies a hole in the leaflet. So
Fair enough,
if it's a
yeah.
gap between and you've lost coaptation, that's
Yeah.
a gap.
So take me to the next part. What's the next thought in there? So the big picture analysis.
Clinical correlation
Yeah, and
and
what do we
referral to cardiothoracic
Yeah, fantastic.
surgery.
So this is early referral for me with someone who's this kind of picture is early referral to cardiology, cardiothoracics, because this is likely, this has the potential to go south, right? With significant, shall we say, mitral regurg, an aggressive bug sticking on a prolapsing valve. This has a high likelihood of not getting better. If this guy's in heart failure or he's, we get worsening of the regurgitation, he's going to need an urgent valve replacement.
This one is for you, Louis.
Oh, thank you, Michelle. Oh, okay, so I'd be concerned that she's either ruptured a papillary muscle or that's probably the most common.
This is from Sam's library.
So starting from the top, no significant pericardial fluid. Right ventricle appears to be relatively normal size and is contracting reasonably well. There is some thickening of the aortic valve leaflets, but they are mobile. With regard to the mitral valve, there is prolapse of the anterior leaflet. And there is something flicking in and out, which could be chordae, or it could be. I don't suppose if you have a ruptured papillary muscle, it could be an end of papillary muscle attached to the chordae.
Sure.
Or did she get thrombolysis? Did you say that?
No.
She didn't.
No.
Okay.
Sure.
Yeah.
Let's go to the next
So
one.
looking at the colour Doppler, we have a large mitral regurgitant jet, which is directed posteriorly.
Okay.
Oh, and there it is again from another view. So it's located on the anterior, around the anterior leaflet, and it's again consistent perhaps with ruptured chordae plus or minus a bit of papillary muscle. And looking at the contraction there, not slightly oblique view. Septal contraction is okay. Inferior contraction is reduced. Can't quite see the anterior and the anterolateral walls terribly well. So looking at the 4-chamber view, consistent with the mobile mass flicking in and out. Enlarged left atrium, which suggests this is a process that's been going on for more than 3 days. There may be some thickening of the ventricular wall that's long-standing, but we couldn't measure that. The mitral regurgitation is directed across the wall and is likely to be severe.
Anteriorly directed, posteriorly directed.
Anteriorly directed. Well, it doesn't really.
So I think it's posteriorly directed.
Okay, I get confused. Anterior, posterior.
Remember, the RV is always anterior, right? That's
Yeah.
It sits at the front. It could be called the anterior ventricle rather than the right ventricle. So anything that goes towards the RV is anterior.
That's just last 2 chamber.
Well, you just see the same appearance with the severe mitral regurgitation directed
So to summarize,
posteriorly. So this lady has probably suffered a known complication of acute myocardial infarction with a ruptured papillary muscle and causing severe anterior leaflet regurgitation, mitral regurgitation.
Yep.
She needs referral. for
urgent,
surgery.
yes, that's true. And just the reason for that, as we know that the posterior medial papillary muscle is, prone to rupture because it's a single blood supply from RCA, whereas anterior lateral papillary muscle, it has dual blood supply from LAD and left circumflex. So that's why in inferior MI, so, always remember that, it's possible to have, this kind of complication. So because posterior medial papillary muscle has single blood supply.
I'll never forget that case. So that case was the day before my 40th birthday. And it was also the day, and also it was the first day of our new echo fellow. So this was one of their first, so they literally arrived, I'd taken them around the unit and someone said, oh, this patient's in bed 23. And it was just a great way to say, oh, welcome to the unit. Oh, we get these cases all the time, by the way. It's one of the most astonishing echoes. It's beautiful.
And last case, Les.
Oh, thank you.
Happy?
Yep. Oh, okay. I'd really love to slow this down because the flicky bits are a bit too fast. But anyway, the posterior leaflet is bowing into the left atrium.
Which scallop?
P2. And I can't really identify the tip because it would either be flail or prolapse. I'd like to see which direction the tip is. I think it's probably directed towards the apex,
yes,
so it's prolapse. Right. And this is associated. Well, the thing I want to ask is, given the gain on transesophageal echoes, you always see a lot more turbulence on a transesophageal echo that's figures highly in the colour picture. So it's easier with a transthoracic to work out how severe it is because you can make all these adjustments that say, oh, this is the right gain, etc. But I never see anyone doing that with a transesophageal picture.
Okay, so I think changing the gain and the scale is really important with transesophageal, just like it is with transthoracic. So the gain arguably can be just too high on this one, as well as the scale not being high enough. So 64 is a little low for someone assessing mitral regurg. We could have that a little bit higher.
That's a zoomed view of the same.
Yeah, better view.
That's pretty. And
Just tell me the scallops, then I'll be happy.
oh, okay. Well, that looks different.
Yep. Let's start with the left side. So only the left side, this is commissural view. So what scallops we see in the mitral commissural view?
A2, P2.
No.
No.
You cannot
I'm guessing.
deny.
I'm totally guessing.
So commissural view is the same as that of your apical two chamber. So A2 in the center. So P1, A2, P3.
Okay. So that suggests it's actually A2 that's prolapsing. So why did that look so different?
It looks a bit different, but it's mainly a P2 and P3, on the detail assessment.
So it's actually mimicking on this.
In this I agree,
level.
looks like this anterior as well, but believe me, it was only posterior.
So A2, P2.
So anything else
anterior
in
on
this?
the right.
Anything else on this particular view?
So A2 scallop on the right, P2 on the left
Mhm.
of the screen. Well, both the valve leaflets themselves look fairly skinny.
Because I thought, there was some flail segment as well in this.
Yeah,
Yes, so because you can see that tip, it's not directed towards the LV, it's directing towards the left atrium. So I think there's a flail segment as well, if you see carefully in the posterior leaflet.
So you're saying flail and prolapse
Yeah.
on the same leaflet.
Because if you see the tip carefully,
It's
so
directed
it's,
towards
yeah.
the.
So I think it's
Well-
both things going on.
It's not going straight backwards.
It is pointing to the left.
It's pointing towards the left atrium. So I think there's prolapse of P2 and P3 and also the flail segment of the posterior the leaflet. So that was
So go back to that one. You don't see it so much in that view.
no.
No.
So only this particular view.
It's only
That's the
that
reason.
view.
Yeah.
Okay.
Yeah. So that was the only view we saw that tip is towards the left atrium. So these were the case discussions. So to summarize, I think to understand the mitral valve prolapse, it's very, very important to understand the mitral valve anatomy and the sonographic anatomy. And as I mentioned, it is one of the most common cause of acute or subacute MR. And to identify which scallop is is affected, it's very, very important to go through the transesophageal imaging to precisely identify which scallops are affected and whether there's only prolapse or there's a flail segment as well. And depending on what we find, mitral valve repair is a preferred treatment option in these kind of patients. Thank you so much.
Great job, Vishal. Thank you very, very much indeed.
Thank you.
That was absolutely fantastic.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And Thanks for watching.